All right. In today's lecture, we're going to talk about the circulatory responses to exercise, how heart rate, blood pressure, and blood flow adapt or change during acute exercise. So by way of outline, first we'll talk about what the cardiovascular system does in response to exercise, and then we'll talk about how it's controlled with exercise. So when you're studying the cardiovascular system, you should be able to do equations like this and figure out what factors will influence mean arterial pressure. One of the most common equations for cardiovascular function is that mean arterial pressure, or average artery blood pressure, is equal to the product of cardiac output times total vascular resistance. Now you should be able to ask yourself, well, what factors influence cardiac output? So heart rate and stroke volume influence cardiac output. What factors influence heart rate? Well, you have sympathetic activity will influence that. What about stroke volume? You have things like preload, afterload, contractility. All these things will influence stroke volume. What things will influence total vascular resistance? So that equation, we have viscosity of fluid times the length of the vasculature divided by the radius of the vasculature to the fourth power. And that radius is going to be the smallest, the one that's important is the smallest radius in the vasculature, which is generally at the level of the resistance arteries. So if we increase heart rate or stroke volume without changing anything, we're going to increase mean arterial blood pressure. If we increase the radius, we're going to decrease resistance and decrease mean arterial pressure. Make sure you can study stuff like this. Also think to yourself, go into Poiseuille's law, which says that flow is equal to the perfusion pressure times the radius to the fourth power over 8 times viscosity times length, and there's like a pi up here. Pardon me. So then you got to ask yourself, all right, if we're trying to increase flow, we want to maximize this perfusion pressure. What's perfusion pressure? That's going to be generally, in most circumstances, mean arterial pressure minus mean venous pressure. And so the things that we do to maximize mean arterial pressure will help increase flow. But let's think about this real quick. This is a good thing to think about. If you're trying to maximize mean arterial pressure, one thing you do is increase total vascular resistance. But if you're increasing resistance, that's going to decrease flow. The way you increase total vascular resistance is by you're increasing resistance to inactive areas. So this total vascular resistance, we could just change this to saying that total vascular resistance is resistance in the active area. That's what the little a I'm using to represent that, minus resistance in the inactive area. And so when you're exercising, you want to decrease resistance to the inactive or to the active area. So this should go down, but you're going to increase resistance to all the other areas. So overall, you'll see an increase. You could see an increase in resistance, which will help increase blood flow. So just play with these equations. Make sure you understand them and practice them. This is a really good thing to work on. Now, let's move on here. So why does mean arterial pressure increase with exercise? Well, one thing is you're going to have an increase in heart rate, which will help increase cardiac output. That cardiac output will also be increased by an increase in stroke volume. So mean arterial pressure is going to go up. Part of it's due to the heart rate, but it's not all. You also can see, especially during like a resistance exercise, you'll see vascular resistance increase exponentially. So here's an example of what's going on. This comes straight from the textbook with blood pressure, stroke volume, and all that during exercise. So if you're looking up here, your blood pressure, your average systolic pressure is going to go up linearly with exercise intensity, more or less. Diastolic doesn't change all that much. It might go up a little bit, might actually in a lot of cases will go down. Because of that, your average blood pressure, on average, blood pressure goes up a bit. Now, you see stroke volume will increase with exercise intensity. And depending on how fit you are, if you have like a really big heart and you're really fit, you might see stroke volume go up the whole time. But if you're unfit, your heart can only expand so big, and so you hit a plateau pretty early. And now let's talk about another equation to calculate mean arterial blood pressure. This is the average blood pressure we're looking at. So your blood pressure does not just go in a square wave where it's like you're at systolic, then diastolic, then systolic, then diastolic. That's not how it works. In reality, your blood pressure goes in a wave to where you go from systolic, here's diastolic, systolic, diastolic, but it's not a square wave, right? You got a lot of time in the middle where you're at some other pressure. Systolic pressure is just your max pressure, and diastolic is the min pressure. So these data I collected when we inserted a pressure transducer in the femoral artery. So these are direct measurements of blood pressure. The blood pressures we take in the doctor's office is all we're getting there is this pressure and that pressure, this pressure and that pressure. So in your ex-phys lab, you might have learned how to calculate or estimate mean arterial blood pressure, which is just average blood pressure. And we estimate that by taking your diastolic pressure, because that's the lowest you're ever going to go. So you know your average blood pressure is at least diastolic pressure, because you don't go lower than diastolic. And then you add the pulse pressure. So pulse pressure is just the difference between your systolic and diastolic. So here to here. So that's what you take there. And now we divide it by 3 because on average, we spend 1/3 of our time at rest in diastole. These data were actually taken during exercise. But during a normal rest, your blood pressure would probably look like something like this. So you spend most of your time in diastole. So because of that, we just estimate that about 1/3 of your time is above diastolic pressure. So we just take the pulse pressure divided by 3. But as I mentioned, these data were collected during exercise, and you can see that you're not in diastole for 1/3 of your exercise. And so the equation that you use like in the ex-phys lab and you'll use like in med school and all these places, it's not perfect. It's an estimate, and it's definitely not perfect for exercise. If you want to make it a little better, maybe during exercise, instead of divided by 3, you might divide by 2 or something along those lines. It's just an estimate, right? So you can increase your cardiac output in 2 ways, right? You can increase cardiac output either by increasing heart rate or increasing stroke volume. Let's say you want to double your cardiac output. Is it going to be easier for the heart to double the heart rate or double the stroke volume? And it turns out that it is much, much easier to increase cardiac output by doubling stroke volume than it is by doubling heart rate. If you look at the energy expenditure of the heart, the best way to measure that, as I'll show you in a second, is by measuring the VO2 specifically of the heart, its oxygen consumption. If you are trying to double cardiac output just by doubling the heart rate, you're going to double the VO2, double the caloric expenditure that the heart has to do. But in order to double cardiac output by doubling stroke volume, you only have to increase your energy expenditure just a little bit. So how do you measure the work of the heart? You can measure it by measuring the VO2 of the heart. And this is a little tricky and very invasive, but what you do is you use this Fick principle and you find the flow through the coronary arteries. So you have to measure that somehow, usually by putting some kind of needle through a vein or an artery and getting all the way up to the coronaries. And then you have to measure the oxygen difference from the coronary arteries to the coronary veins. So this is all very, very invasive, but you can measure the the energy expenditure of the heart. Other studies have found that you can kind of estimate the energy expenditure of the heart by calculating the systolic blood pressure times the heart rate. This is often called the rate pressure product, or sometimes referred to as the double product. This is a good way to estimate the work of the heart, the VO2 of the heart. When you guys go to med school or any other kind of graduate school, you might learn a little bit more about these pressure volume loops, where it's just showing you the volume of the ventricle during diastole. You're filling it up, and then when you start to go through systole, you contract, increasing pressure without changing the volume, and finally you get the pressure high enough that it ejects the blood, volume goes down. So you don't have to know these pressure volume loops for your class, for this class, but in a lot of medical professions, they estimate the work of the heart by something called stroke work, which is just the change in pressure times the change in volume, or the area of this box. It's an estimate, but it's not a perfect estimate of the heart. In my opinion, I think that obviously the gold standard is the VO2, and then the rate pressure product probably tracks the VO2 a little bit better. And here's the reason why. So let's say if you want to increase your cardiac output, you can either increase it by increasing the volume of the heart, like the stroke volume. So just mostly by increasing preload or decreasing afterload. So you get a bigger volume of the heart. It's only going to increase your VO2 or your energy expenditure a little bit. Whereas if you want to double your if you want to double cardiac output by doubling heart rate or doubling contractility, or whatever you want to do, that's going to double your VO2, your caloric expenditure. So it's a lot more efficient to double your cardiac output by doubling stroke volume. And one of the reasons for that is that when you're increasing, if you're trying to increase cardiac output, you only have to increase the radius of the heart a little bit, because volume of the heart is related to a third, is like a cubed of the volume. Just a small change in radius equals a big change in volume. And so you don't have to change the size of the heart very much to get an increase in stroke volume or cardiac output. And now if you want, you can go look at this website. We'll talk about it a little bit more. It's a great website. I recommend it. But overall, it's just much more energy efficient for your heart to increase cardiac output by increasing stroke volume, usually preload, or the size of the ventricle. Now, for that reason, most of endurance training, you're not going to increase your cardiac output by increasing your max heart rate. It doesn't happen. Your max heart rate stays pretty similar, might go down a little bit. You're going to increase your max cardiac output and your max VO2 by increasing your stroke volume. And a lot of that is going to come by having a greater end diastolic volume, because it costs less ATP. The details on why that is, you don't have to know for this class, but just as you go further in your education, keep that in mind, that it's a lot easier, more energy efficient to increase cardiac output, to facilitate a high VO2 by increasing stroke volume and end diastolic volume. Now, in an earlier video, I was talking about coronary artery disease, where you can have the plaque build up enough that it impairs blood flow downstream. And now all of a sudden, or maybe not all of a sudden, it often develops over time. Now you have the coronary arteries, these conduit arteries, being points of resistance, the greatest resistance, more than your arterioles. Usually your arterioles provide the greatest resistance and dictate flow. But if this plaque gets big enough, it can cause the radius to get small enough that now this is the point of resistance, and it will reduce your blood flow. That can cause a big O2 deficit and cause like metabolite accumulation, chest pain. So like when you've done intense exercise and you feel that burning in your legs or wherever you're exercising, that's an O2 deficit, part of it, with the accumulation of metabolites and other things. Now you'd have a similar scenario going on your heart, and that would cause angina or chest pain. Now that O2 deficit is an imbalance between your ability to deliver oxygen and how much oxygen your heart is demanding. So to restore equilibrium, you have two choices. You can either decrease your oxygen demand, and that's what you're going to do when you first get that chest pain. You feel that chest pain, you're like, okay, I got to stop exercising, like decrease my heart rate, decrease the stroke volume and the work of the heart. And so people that have coronary artery disease will probably avoid exercise to avoid that kind of chest pain. Now, you can also restore balance by improving oxygen delivery. And that can come in by putting in a stent or a bypass. Let's talk about a bypass. So in a bypass, let's say your clot is right here. You can put in a vein or an artery to go around that clot to restore the blood flow. And now you can increase oxygen delivery and improve your oxygen deficit so you don't get as much chest pain during exercise. So now here's another scenario that's really important. Let me introduce you to these data I collected a couple years ago. I had a bunch of dudes do some exercise, and we measured blood pressure directly in the femoral artery. This is like the real blood pressure, not estimating with a blood pressure cuff or anything like this. There's a pressure transducer in the artery. While they did a normal two-leg cycling exercise, and again, while doing a single leg knee extension exercise, which is basically single leg cycling. Now, look at the blood pressure response at, let's say, 40 watts, right about here. On a bike, it's very low blood pressure. But doing that same kind of exercise on a knee extension ergometer with one leg doing the exercise, the blood pressure response is much higher. Same power output, same amount of ATP consumption, but the blood pressure response is much, much higher doing it with a single limb. And it's not even just a single limb here. During this exercise, the exercise is limited to the quads. Whereas when you're doing a cycling exercise, you got the quads, the hammies, the calf, the glutes, all in both legs involved in the exercise. But if you do all that exercise with one muscle group, you're a single quadriceps group, the blood pressure response is much, much higher. By the end of today, you should be able to explain why that is. Actually, not by the end of today. You should know already enough to do this. So let me break this down again. The total vascular resistance is going to be the sum of the resistance in the active area versus resistance in the inactive area. Now, whenever you're exercising, you get a sympathetic response to all the vasculature throughout the body. And that's going to cause vasoconstriction in most of the arterioles throughout the skeletal muscle. And in the inactive area, that's going to cause vasoconstriction. And so resistance should increase in the inactive area and decrease in the active area. Now, one of the reasons why blood pressure is going much higher during the single-legged exercise is that you're only decreasing resistance in a small part of the vasculature and increasing resistance in a large inactive area. In contrast, when you're doing two-legged cycling or something else like running or whole body exercise, you're decreasing resistance in a very large area all throughout the body. And so you're dropping resistance a lot, whereas your signal for vasoconstriction is only happening in the inactive areas, which is going to be a relatively small amount of muscle. So the more muscle you're engaging for a given power output, the greater the decrease in resistance. So single leg exercise or single arm exercise can drive up blood pressure a lot higher for a given power output than if you distribute that across multiple muscle beds. Because then if you're using multiple muscles, you're dilating multiple vascular beds and you're dropping the total vascular resistance. Now, it's for this reason that people who have weak hearts are often suffering from angina or that O2 deficit in the heart. They're advised to avoid arm exercise, because if you're doing arm exercise, you're only dilating or decreasing resistance a little bit in the small arms, but you're increasing resistance in the rest of the body, which is inactive. So overall, you'll see a large increase in resistance, which will then cause a big increase in mean arterial pressure or afterload on the heart. So the heart is going to have to pump a lot harder, push a lot harder to get blood out. So exercises that are going to drive up blood pressure really high can elicit angina a lot faster than exercises that have a drop in resistance that will not elicit and thereby are easier on the heart. So anything that's going to increase your vascular resistance a lot, you have a high risk of chest pain because you're making the heart work a lot harder than normal. And so single arm exercise or arm exercise is going to increase blood pressure a lot. Resistance exercise, true to its name, resistance exercise increases vascular resistance a ton, which will then make the afterload on the heart really high. That means arterial pressure goes up, so afterload goes up and the heart has to pump really hard, causing it to consume more ATP, exaggerating an O2 deficit in the heart, which can elicit even more angina. All right, now how does the body control, or how does the body respond to exercise? Cardiovascular system. This is an excellent diagram coming from your textbook. Make sure that you understand all the stuff that will influence cardiac output and blood flow. So your blood pressure and blood flow response to exercise is controlled primarily in what we call the cardiovascular control center. And this is going to be like in your brainstem in this area. And it's going to integrate signals from all over the body, signals from the heart, signals from the exercising muscles, signals from the arteries, signal from just all over the place, right? Signals from the upper brain saying, hey, it's time to exercise. They all converge down on that cardiovascular control center and basically are raising or lowering the membrane potential towards threshold to increase sympathetic activity or away to decrease sympathetic activity or parasympathetic activity. So our cardiovascular control center, what we'll see, you're getting influence from a couple of main areas. You'll have information coming from baroreceptors or pressure sensors in the heart, or in the arteries and in the heart. You'll have information coming from chemo and mechanoreceptors in the muscle, and you'll have information coming from the brain. And all of that converges on the cardiovascular control center, which then will alter the tone or the diameter of the blood vessels and your heart rate and contractility. All right, so let's talk about this idea of central command. So when you start to generate an action potential to cause your muscle to contract, that action potential goes down like the motor cortex to the spinal cord, down the spinal cord to cause the muscle to move. As those action potentials are being relayed to the spinal cord, the signal is also relayed over to the brainstem. So even before the muscle moves, this cardiovascular control center is getting information that you're going to exercise. So the cardiovascular control center knows before the muscle that the muscle is going to exercise. It's pretty cool. And in preparation for that exercise, the cardiovascular control center will decrease the parasympathetic inhibition and increase sympathetic activity, which will increase your heart rate. So here's a really cool study. This one was done by infusing something called Coronary, which we've talked about in the past. It's blocking the communication or inhibiting the communication between the motor neuron and the muscle. So in order to get the muscle to contract, let's say that you get poisoned with curare and you poison half your receptors. So in order to get the muscle to contract at a normal level, you have to release twice as much acetylcholine, or roughly twice as much, to get the same amount to get you up to the muscle up to threshold. So by poisoning these people with curare and having them do the same amount of exercise as before, their they're making the brain send twice as many action potentials down the motor neuron just to do the same amount of work, same amount of ATP consumption, because this junction right here, the communication is impaired. So you got to have twice the signal to get the muscle to respond the same. So when they do that, when they poison the people with Curare and had them do hand grip exercise, no, this is cycling, had them do cycling exercise, same power output. Here's the blood pressure response to the light exercise when they're not poisoned or blunted with the Curare. And here is the same exercise intensity, let's say 100 watts, but now with Curare impairing the communication between the nerve and the muscle. So in response to that Curare, in order to keep doing the same amount of work, have the muscles contract at the same rate, they have to send twice as many action potentials down to overcome that inhibition. So that means the brain is generating twice as many action potentials. So central command is going twice as much, and it causes you to exaggerate the sympathetic response and the blood pressure response. Now you get a similar thing happening with fatigue, right? So without Curare, you can have a similar response. So if the muscle is not generating as much force as normal, now you have to recruit more muscle to get the same amount of work done. And more muscle means more action potentials being generated in the brain, which means more central command, which is going to exaggerate your blood pressure response and your heart rate response. So fatigue is going to increase your central command, or the feed forward aspect of your cardiovascular response, and cause you to have a greater heart rate and blood pressure response. Now you have another scenario, another set of things that is sensing, controlling your blood pressure and heart rate response. The central command, this is a feed forward thing. It's like a rough guess based on how many action potentials are going down. The heart or the brain is telling the heart and the vasculature to respond to roughly this amount. So it's a feed forward guess to get you in the right ballpark. Now, these other things that we'll talk about, the baroreceptors and the chemo and mechanoreceptors, these are feedback systems. They're going to take whatever the feed forward did. So the feed forward system roughly, like really quickly adjusts your heart rate and your blood pressure response up. And now the baroreceptors and your chemomechanoreceptors are going to fine tune that to be right in line with what the exercise is. So your baroreceptors, these are pressure sensors in the aortic arch right here and in the carotid bodies. So right there, same place that you're sensing your PO2 and your PCO2 in the arterial blood. You also have these pressure sensors, and they are sensing whether or not your blood pressure is sufficient enough. Remember, in order for blood to keep moving, you have to have pressure. If the blood pressure goes too low, the blood stops moving. So your body's very concerned about maintaining a sufficient blood pressure to keep blood going up to your brain or wherever it needs to go. So these pressure sensors in the heart, I'll tell you about that thing in a second. These pressure sensors in the aortic arch and in the carotid arteries, when they're activated, when they have stretch on them, if they're being stretched, they sense that blood pressure is really high, and you don't want high blood pressure. And so when they're being stretched, they inhibit the sympathetic nerves so that they stop increasing heart rate and stop increasing contraction, which should then decrease blood pressure. Let's look at it in another way. Let's say that you get some terrible injury and you're hemorrhaging, you're losing blood. So your blood pressure is going to drop. So that means that the pressure in here is not very great. It's not pushing out, keeping the artery inflated. And so that pressure outside of the artery could start to push the artery in, and it can start to shrink. Like your artery is basically deflating, like a popped balloon. Now, that's because you're hemorrhaging, losing blood volume. Now, you need blood pressure in order to keep blood moving. And so in response to low stretch on it, the signal, this inhibitory signal to the sympathetic nerves will be gone. So now that's turned off, and now your sympathetic nerves will fire uninhibited, increasing heart rate, increasing stroke volume, increasing vascular resistance to hopefully drive blood pressure back up where it needs to be. These baroreceptors are very crucial to sensing your blood pressure and making sure that it stays in an adequate area. Now, they're almost like a thermostat. Let's say that your blood pressure, your baroreceptors right now, let's say they want to keep you at an average pressure of about 93 millimeters of mercury, your mean arterial pressure. If they sense that it's dropping down below that, let's say that you get that hemorrhage and now your blood pressure is, you're losing blood and your blood pressure goes down to 70 millimeters of mercury. You want to increase the heart rate, cardiac output, and the resistance. Remember, mean arterial pressure is equal to cardiac output times total vascular resistance. Cardiac output is influenced by your heart rate and stroke volume. And this is primarily, the resistance primarily related to the radius of your vasculature, of your resistance arteries, mostly. So if you sense this drop in blood pressure, you're going to increase sympathetic activity. You're going to take the brake off. This thing's gone, and now the sympathetic nerve should be able to work uninhibited. So heart rate and stroke volume will both increase, and you'll get norepinephrine going to your nerve, to your arterioles, which will cause constriction, driving up resistance, and hopefully increasing blood pressure. Now, the pressure that they try to maintain at rest is on average somewhere around 93 millimeters of mercury. That's just stereotypical 120/80 blood pressure. But when you exercise, you need an even higher blood pressure to get flow going faster. And so instead of your brain saying, let's maintain 93 millimeters of mercury, the baroreceptors in your brain now say, instead of 93, let's maintain 100 millimeters of mercury. So they try and guard a higher pressure. So they'll increase heart rate or decrease heart rate and resistance in response to this pressure instead. These baroreceptors can go dysfunctional with aging. One thing that's been observed is that with aging, they start to guard a higher pressure. And so this can contribute to hypertension with aging, just because these things are now maybe less sensitive or messed up. And instead of guarding, trying to maintain you at 93 millimeters of mercury, they've gotten messed up and are now trying to maintain you at 100 millimeters of mercury instead. So that can be a problem. So this is an area where you might be able to intervene to try and improve blood pressure in people with hypertension. Now, another factor, that feedback mechanism for controlling your cardiovascular response to exercise, is coming from the sensory afferents. So in the past, we've talked about the type 1 through 4 afferents. So 1 and 2 are your muscle spindles and Golgi tendon organ. So when you start to move your muscles and cause stretch on these the muscle spindles and the GTOs, you'll get a cardiovascular response. Your more pertinent to exercise are your type 3 and 4 afferents, and these ones are embedded within the skeletal muscle, and they're sensory and mechanical stretch in the muscle itself, and also metabolic disturbance. So if you start to get a drop in your pH, becoming more acidic, they sense it and will increase blood flow and blood pressure in response. So these afferents, when they're activated, will try and increase your blood pressure response. So let's think about this. So your chemoreceptors, these type 4 afferents primarily, are the chemoreceptors. Let's say that when you're exercising, here's your O2 deficit curve. You need this much ATP. And as you start to exercise, you get this O2 deficit. All right, so you increase your blood flow this much. And so you have aerobic metabolism, trying to resynthesize your ATP, but you have this huge O2 deficit over here. And that's because of that O2 deficit, you're going to have a lot of acid and other metabolites produced. That acid and metabolites activate the sensory nerves, which then relay back to the cardiovascular control center to increase cardiac output and blood pressure. Now, the idea behind that is that if you can maybe increase blood flow, or your O2 deficit could have been because you had inadequate blood flow at that exercise intensity. So with increasing blood pressure and blood flow, now your heart rate and blood flow will go up, and you might be able to minimize that O2 deficit. So that's where the afferents are coming in. They'll try and increase blood pressure and heart rate to hopefully increase your oxygen delivery to the muscle. But this can be problematic as well. Let's say that you're fatiguing, okay? So you're really out of shape and you're going to have a greater O2 deficit than normal. Let's say before your mission, you were in great shape and you can get your ATP resynthesis mostly aerobically, so you're not going to have a lot of metabolites. And so you have just a small O2 deficit, a few metabolites going in to stimulate your heart rate and your blood pressure. Now, let's say you go on a mission and just sit in a car for 2 years. Now, when you do that same exercise, the ATP cost will be roughly the same, but your VO2 max and all of that will be lower. And so now you have a much greater O2 deficit. And that's going to cause more acid to accumulate, going to stimulate the muscle afferents more, which is going to tell the cardiovascular control center that whatever it's doing right now is insufficient. And so it will increase heart rate and blood pressure even more. And so you can get an exaggerated blood pressure response if you're out of shape. This kind of process will happen as you're fatiguing too. As you start to fatigue, you're going to produce more acid, which will cause the afferents to increase their activity, and blood pressure will go up as you fatigue. So let's say you're doing an exercise where, like you guys remember, maybe the VO2 slow component. Let's say I put you at like 90% of your critical power. So your VO2 is going to go up, and then it'll keep going up until you hit max. If we do that if we measure blood flow simultaneously, now this will be Q. You'll start off with blood flow going up really quickly, and then as you fatigue, blood flow will increase higher and higher. But probably more important to our discussion today, we'll talk about mean arterial pressure. It'll go up really quickly, and then it will also increase higher and higher. As you're increasing your fatigue and increasing that O2 deficit and how hard you perceive the exercise, all of these things, your central command, and these things will be exaggerated. The afferents will be exaggerated to drive your blood pressure and your heart rate up. Sorry. Oh, let me show you this. So here's a cool study. These are actually pretty easy to do, these kind of studies. So in this study, they had people do arm grip exercise or hand grip exercise. So they're just squeezing this stick, and they had people do it while they measured blood pressure. And so let's focus on these people here first. This is normotensive individuals, the black dots. So when they're at rest, their blood pressure is down here. As they exercise, they have all these things going on: the central command, the baroreceptors, the chemomechanoreceptors. Those all come into play to increase mean arterial pressure. And then they stop exercising. Follow this line. If they stop exercising normally, your blood pressure will go back down. But in this study, what they did is they had them stop exercising, but as soon as they stopped exercising, they inflated a blood pressure cuff. So now the metabolites that they produced are stuck in the muscle. They're not exercising anymore, so there's no central command. And just by trapping the metabolites in, they keep the blood pressure up. And as long as the blood flow is stuck and the metabolites are stuck in there, the blood pressure stays high. This shows that your metabolites signal for that are contributing to the increase in blood pressure with exercise. And if you're terrible at clearing out the metabolites, the blood pressure will stay elevated. Now, they also did this in individuals with hypertension. And so their blood pressure, the hypertensive, started out right around here. And as they exercised, they had an exaggerated increase in blood pressure. So that could be due to many things. It could be due to the central command. Maybe they're just really out of shape, and doing that same amount of exercise is really hard for them. So they're sending a lot of action potentials down to the muscle and through the cardiovascular control center that drives up the blood pressure. It also can be, and this is very likely, that people with hypertension have impaired resistance artery health, so that they have a lot more vascular resistance than normal. They don't dilate as well, and that drives up the blood pressure really high. So their blood pressure goes up really high, and then they have them stop exercising, and blood pressure stays elevated afterwards. So they also can be very sensitive to those metabolites. Sometimes you'll find people where you have them stop exercising, and so you're just, the difference basically between here and here is how much the metabolites are contributing to the blood pressure response. And so you can see that in these hypertensive individuals, the metabolites appear to cause blood pressure to go up even higher. So maybe they're either more sensitive to metabolites. So if you expose them to a given amount of acid, maybe these hypertensives, their afferent nerves are more sensitive, so they have a greater response. Or it could just be that because they're out of shape, maybe they're producing more metabolites than normal. So they're stimulating the afferent nerves more than normal and getting a greater blood pressure response. Either way, these sensory nerves are really influential for your blood pressure and heart rate response. What else can I tell you about these? We've done some studies where we actually block the communication between the sensory nerves, or impair it, the sensory nerves in the brain. So you can't really tell how much metabolic byproducts or how much mechanical strain is going on in the muscle. And when we block that communication, the chemoreceptor and mechanoreceptor response to the CV center is blunted. Like they just don't know. This cardiovascular control center doesn't know what the muscle is seeing. And as a consequence, the heart rate, the blood pressure, and the blood flow response are lower, and they get less oxygen down to their muscle than they need. And so their exercise performance is impaired. So the idea of these afferents, part of it is to make sure that you're getting adequate oxygen delivery to the muscle. But they can also be too sensitive. There have been some studies showing that these afferent nerves are overly sensitized in some hypertensive people, so that in the presence of just a little acid, they have a way exaggerated response. So this is another area that in the future, we might see some medications or treatments targeting the afferent nerves to hopefully blunt the blood pressure response to exercise in hypertensives. All right, that's all for today. Make sure to study up on what controls blood pressure and heart rate during exercise. Let me add one more thing now that I think about it. Where are we? It was right at the beginning. This. So your increase in heart rate, your heart rate goes up really quickly at the start of exercise, very rapidly right here. In the first couple of seconds, as soon as you get out of your chair and start walking, your heart rate's going to go up like 20 beats per minute or more. That initial increase in heart rate and cardiac output, a lot of that is going to come by parasympathetic withdrawal. At rest, your heart rate is being slowed down by the parasympathetic activity. So if this is your standard action potential diagram where you have millivolts, and this is threshold, In order to get an action potential generated in the heart, you have to go up like that. You need to hit threshold. Under normal circumstances, if you have no innervation of the heart at all, the heart rate will naturally depolarize. It's leaky. It will depolarize itself to threshold about 100 times per minute. But your resting heart rate is not 100 beats per minute because right now you have parasympathetic activity slowing the depolarization rate. So you have these IPSPs decreasing the rate of depolarization. So now it'll take you longer to reach threshold. Well, when you exercise, you take out, the first thing you do is take off the parasympathetic inhibition. So now you're going to reach threshold faster. Right, so that can get your heart rate up to about 100 beats per minute right away, just by taking the brakes off. The parasympathetic activity is slowing down your natural heart rate. And then as you start to increase heart rate more, now you have the sympathetic signals coming in, increasing it even further, so it gets to threshold even faster. So your initial increase in heart rate and cardiac output is largely due to the removal of parasympathetic activity. And that'll get you up to about 100 beats per minute. And then beyond that, most of your increase in heart rate is going to be due to sympathetic activity. All right, that's all for today.